Hi, my name is Nick Kuntz. I'm a neuroradiologist at Mayo Clinic, Arizona. And today I'm going to talk to you guys a little bit about what is really probably my favorite part of my job, and that's performing imaging-guided head and neck procedures. And I think that for those of you who know me, you know that my favorite part of neuroradiology is head and neck imaging, which is just, the most amazing thing in the world. But within head and neck imaging itself, I really enjoy doing these head and neck imaging-guided procedures because it's an opportunity to actually interact with patients and really feel like I'm doing something hands-on that's directly contributing to patient care. And not that interpreting the medical imaging isn't, because that is a huge part of patient care. But I really enjoy this. I got a lot of personal satisfaction out of it, and I really treasure the opportunity to interact with patients doing these. So for the next, I don't know, however many minutes, we're going to talk a little bit about some of the things that I think are important to know about imaging-guided head and neck procedures. I don't have any financial disclosures. I am going to report some specific names of devices that I use. I want to be very upfront. This is not an endorsement of those products in particular. It just happens to be what I use. That's what I know. Honestly, my take on any sort of procedure is use the tool that you're most familiar with and that you're most comfortable with, because you're going to be the most successful with that. I will talk very briefly at the end about off-label use of intrathecal gadolinium for skull-based cysternography. And I am including some actual photos that were taken during a biopsy. I took these with the patient's permission. They knew that I was putting together a lecture on this, and they were very happy to contribute to it. The patient is completely anonymized, de-identified, so just rest assured with that. It is all up and up as far as on the up and up as far as HIPAA and safe harbor criteria are concerned. So. All right, I would also like to thank a couple of folks. First of all, Clarissa Lundgren in the pathology department here at Mayo Clinic, Arizona, who was very helpful in sending me some slides that have to do with the actual acquisition containers and solutions that we use whenever we're taking these samples. And so I'll talk a little bit about what the different types of tissue need to go into when they go to the pathology lab, as well as Jen Keller, who's one of our phenomenal CT techs here at Mayo Clinic, Arizona, who does procedures with me and was kind enough to serve as a model as we're kind of mocking up how it looks when a patient goes into the scanner. But I promise I did not stab her with any needles as part of this. Okay, so here's the objectives. I'm going to talk about sort of an overview of imaging-guided head and neck procedures. We'll talk a little bit about ultrasound. This is mainly a CT talk, but I do want to share some of the pros and cons of ultrasound, because I think it can be an incredibly powerful frontline tool to use. In fact, I like to use ultrasound when I can, because it is a very nice tool, and we'll talk about the reasons why. I'll talk about the specific supplies and equipment, some of the technical considerations in terms of patient positioning, and then we'll talk about the typical approaches that we can use to reach most of the deep spaces within the head and neck. And then at the very end, I'll talk just a little bit about skull-based CSF leaks and the different tools we have to work those up. Okay, so let's start from square one, all right? I think everybody who's in medicine has heard this, the first do no harm. That really needs to be first and foremost whenever you're considering doing one of these imaging-guided procedures. You always want to think in your mind before you ever agree to doing it, do the benefits of doing this outweigh the risks? Most of the time, I would say that's probably true. The benefits are incredibly important, figuring out what kind of cancer the patient has, do they have recurrent cancer, doing molecular testing on whatever the samples you take in order to better tailor the treatment care. But sometimes you get requests to do procedures that probably should not be done. And that's a conversation that you need to have with the ordering folks and figure out the right next steps. So really the question should always boil down to, will whatever you're going to do, will it impact the clinical management of that patient? I think it's really important with these head and neck biopsies because we're dealing with a very small space and there's not a lot of wiggle room, and there are some very, very important vascular structures, such as the carotid and vertebral arteries that live here. I think it's important that you have a safety net, and I like to have a neurointerventional or endovascular neurosurgical safety net. And, there have been times in the past where if I'm doing a biopsy of a small lesion that's right up against the carotid space, that I will reach out to either neurointerventional or endovascular neurosurgery, whoever's covering endovascular call, and just let them know, this is what I'm doing. I just want you to be aware in case there were to be any sort of vascular injury. I want to have a plan in place for what needs to happen so that we're not scrambling, trying to figure it out on the fly. And they have always been very appreciative of that heads up, and it's a good collegial working relationship to have. And then you also want to make sure that you do the appropriate pre-procedural assessment and post-procedural assessment and monitoring as well. For most of what we do in terms of head and neck procedures and these imaging-guided biopsies, you do want to have some basic labs. You want to make sure that the platelets are greater than 50,000 and the INR is less than 1.5. And then it's really important that you know what medications the patients are on in terms of their bleeding risk, whether they're on aspirin, Plavix, Coumadin, any sort of medication that's going to increase their risk of bleeding. If they are, you need to make sure that they've gone through the appropriate mechanism in terms of holding the medication ahead of time and resuming it after the procedure is over. And I'm not going to go into any further depth about that. There are resources that you can find in the medical journals that will help to dictate what you need to do for that. All right, so the next thing is you want to clarify the plan. Okay, so this is a time when, as a radiologist, you want to be in close communication with the ordering docs. Usually it's going to be the head and neck surgeons. Sometimes it comes from neurosurgery, depending on what we're doing. But you always want to figure out, what does the patient need to have done? And then you have to think, is it an appropriate thing? And have we all agreed upon the particular target lesion? Because sometimes patients have multiple lesions. You want to make sure that you are, for example, doing a biopsy on the specific lesion that the ordering team, whether it's otolaryngology, head and neck surgery, neurosurgery, radiation oncology, whoever, you want to make sure you're on the same page. You also want to review all of the salient pre-procedural imaging. Because head and neck anatomy is so complex, you want to be familiar with that patient's specific anatomy. I think that in terms of doing these procedures, knowing and understanding the anatomy is like 95% of the battle, okay? So whenever you're planning these out, you really want to think to yourself, can I get a needle safely to that lesion in light of their anatomy? And you always want to do a standard timeout ahead of time just to make sure everybody on the team is on the same page. I love this graphic here because really, whenever I'm doing one of these procedures, I want to have it planned out up front and I know exactly what I'm going to do. It's almost like playing baseball. You want to know what you're going to do with the ball if it comes to you before that play ever happens. You need to think about these cases like that. You don't want to be reactionary, you want to be proactive. And then you also need to keep in mind, is this a case that I want to have on-site cytopathology? There's variation in clinical practice as far as how that's done. I've been at places where cytopathology comes for all head and neck biopsies. I've been at places where they're available upon request. And so if it's something pretty routine and you feel like it's a large mass or a large lesion and you're not too concerned about checking for sample adequacy, that's one thing. But if it's a small lesion or you don't want to run the patient through the ringer, we never want to put them through more procedures than they have to be. But you don't want to have to do a risky procedure again because you have an insufficient sample. Those are times that you might want to think about having cytopathology come down to the procedure and look at your slides and make sure you've got an adequate sample. We always want to do an informed consent procedure before we ever do the case. You want to take the time out to do it right. You want to keep it simple. Don't use your big fancy words. Put it in words that the patient will understand, okay? Don't use those doctor words. Keep it simple. And you want to talk to them about what the plan is, what the risks are. And I always tell them there is a chance that it could end up being a non-diagnostic result. Obviously, you want to let them know what the potential alternatives are. And I think that it's really good to let them and their family members who are with them know about how long the procedure can take. Because while you may be sweating it during this, doing this case, have some anxiety, I guarantee you that your level of anxiety is not as high as the family members of that patient that's getting the procedure done. So, you don't want to say, oh, this will be a quick procedure. And in your mind, quick might be 45 minutes or an hour. and then the patient's family is sitting out in the waiting room fretting about, is there something going wrong back there? What's happening to my family member? So just be upfront with them about how long you think it will take. And if you're going to do anything that's off-label, I think that you need to let the patient know about that and make that decision. So, specific to this talk, I'll talk later about intrathecal administration of gadolinium. That's the kind of conversation you need to have with them and make sure that you have their permission to do. And then, after you've gone through all of that, shut up. Let the patient talk, listen to the patient, don't interrupt them, answer their questions, okay? Most of these head and neck procedures, I end up using moderate sedation. Pretty much I use it for all of my CT-guided biopsies. Occasionally I'll do it for ultrasound-guided things as well. And in order to do that, you need to make sure that everybody's properly trained, including yourself, having appropriate sedation credentials, ACLS, all of that. But you want to have a sedation nurse. They're typically the ones that are pushing the drugs, sort of at your supervision and monitoring. And you want to have a safety net. It's always important to have safety net. I talked about the endovascular safety net. You also want to have a safety net here. That safety net is going to start with your pre-procedural physical exam to assess their risk, get a good history, know whether or not they've got cardiac disease, lung disease, etc. These patients need to be on the monitor. They need to have an IV in place. Obviously, they do to push the sedation meds, but also in case something were to deteriorate, you want to have that central access. I always have a nasal cannula on the patient, always do it before the procedure. I've had times where you get started, get the patient started to get them prepped and draped, and you realize, they don't have any supplemental oxygen on. And so then you got to start all over, break the sterile prep that you were doing. So I have it on from the start. It's a safety net. Sometimes if you're working around the face, you have to tape the oxygen tubing up on their forehead to get it out of the way. But you also want to make sure that you've got the appropriate airway equipment and a crash cart just in case something were to deteriorate. And then obviously you need to have the drugs, both the sedation medicine as well as their antagonists in case they get a little too sedated, because you want these to be moderate sedation and not achieving general anesthesia. All right, as far as pathology supplies go, this is kind of a standard kit, and it will have slides for you to do your fine needle aspiration with. You're going to have, at least in our shop, we have an alcohol-filled Copland jar. Whenever you put your slides in that, something that I learned from talking to the pathology department, you want to put those slides back to back. You don't want to put sample side against sample side because it can smear, smash, and really damage the sample and make it a non-diagnostic assessment. So put those slides kind of butt to butt so that that the sample sides aren't touching. There's a product called Cytolite, which is shown right here. Cytolite's nice whenever you've got a bloody sample, because what that does is it lyses the red blood cells, and then the pathologist can sort of spin that down and get a better assessment of any sort of tissue that's in there. And I like to rinse my needles when I'm done in Cytolite as well. If you're taking the time to put the needle in there, you want to make sure you get every last cell out of it that you can. Sometimes we'll send for RPMI. That's particularly for the use of flow cytometry in patients that you suspect lymphoma may be involved. And then formalin. Formalin is what we put core biopsy samples in. And then not shown on this picture also would be sterile saline. And that's what you can put any sort of samples from microbiology. Your shop may have specific tubes that they want that put into, but always clarify with your own pathology department up front. This just happens to be what we use at my current shop in terms of the basic supplies. All right, so enough of the introduction. Let's talk a little bit about ultrasound-guided biopsies. And again, I won't talk too much in depth about this. I think in most places, this is done by ultrasound people or body imagers. But I do think it's a great tool. And if you're comfortable doing it, I think you can save yourself a lot of time by being able to do these procedures under ultrasound guidance. So what are the pros of doing ultrasound? I think it can be very quick. It's nice for superficial lesions. And what's really nice is you get that real-time visualization of whatever you're scanning. So not only can you see the lesion in real time, but you can also see the vessels in real time. So it's nice to be able to watch in real time as you advance the needle in and avoid putting it into structures like the carotid artery, for instance, that you don't want it to be into. And then, ultrasound doesn't employ ionizing radiation. it's important to think about ionizing radiation and radiation dose, but most of the time these are patients who have cancer or you're concerned about cancer. So when you weigh the risk of ionizing radiation exposure, against the fact that they may already have cancer, yes, it's important, but it's not something that ever stops me from doing a procedure. And this is sort of a standard ultrasound setup. You can see the patient is draped with these sterile towels. We've got the ultrasound probe here, this linear transducer. We've got a sterile cover over the ultrasound. There's sterile ultrasound gel. And then I'm using that in real time, putting the needle in and watching it all the way down to the target lesion. Cons. Well, ultrasound is great for superficial stuff, but it's limited for deep lesions due to both the depth of penetration as well as the fact that you've got small windows that you're dealing with in the head and neck, and you've got bones that can shadow things out. Many of these patients are post-op, so you may have surgical clips that are also shadowing things out. And, ultrasound-guided procedures are certainly operator dependent. And that's something that, you need to know your own limitations up front. This is sort of just a standard procedural tray that we might use. Sterile towels. We've got the sterilizing solution, the chlorhexidine or whatever this is. Some sponges to apply it. We've got some syringes that we use to have on the back of our needles as we take our samples. And we've got these labels. I think it's critically important. You always want to label whatever liquids you're dealing with. Obviously we're not giving iodinated contrast here, but you can imagine if you're doing a CT-guided procedure and you've got contrast in one syringe and lidocaine in another, you don't want to mix those up. So always be labeling stuff. Here again, sterile gloves, sterile field, sterile drape, sterile cover over the ultrasound probe. Cleanliness is next to godliness as far as this goes. And this is how the patient is positioned. You can see this is sort of our target area at this parotidectomy site. We're looking for an area of recurrent disease. We've got our monitor over here so that I can watch in real time as I do this. I like to use a little bit of acupressure technique. I know it sounds kind of like hippy-dippy, baloney, but I think that whenever you're going to numb up somebody's skin, I always take the backside of the needle cap and just push it against the skin and prod and turn it just a little bit. It's the same thing when you go to the dentist. Hopefully you don't go to dentists that whenever they go to numb you up, they just jab you in the gum with the needle. Usually they massage it and sort of trick the neurons to sort of depolarize or do their action potentials, and that can sort of take away some of the initial pain with the numbing. It doesn't take it all away, but it helps to sort of mitigate it a little bit. So then once I've done that, I'll numb up the skin superficially. And then we'll start working on doing our ultrasound-guided biopsy once everything is nice and numb. And so this is sort of the setup I use. I've got these small 25 gauge needles here that are on 10 cc syringes or 10 milliliter syringes. I have them all lined up ready to go so that I can just pull them off the tray and be ready to do the procedure. And this is what it looks like in real time. So this is what I'm looking at on the monitor. This is what I'm doing. I'm holding this steady. I have the lesion locked into place, and I'm sort of using this pistoning technique to take samples with fine needle aspiration using this capillary action. And you can do that. I tend to do my first pass or first couple passes without any aspiration, just strictly capillary action. And then I'll do a few passes with some gentle aspiration as well to try to suck up any additional tissue. All right, so that was the quick overview of ultrasound-guided head and neck biopsies. The big portion of this talk is going to focus on CT-guided procedures. So whenever I'm doing CT-guided biopsies, I want to make sure that I've got the appropriate equipment. You want to be using a scanner that's got CT fluoroscopy. I do all of these as a coaxial procedure. I do that because I can place an introducer needle all the way to the lesion, and then through that, I can take my samples. That way, you're minimizing the number of times you're sticking the patient. All right, park the introducer where you want it, take all your samples through that with a smaller gauge needle. So I tend to use like a 22 gauge, 9 centimeter, either MaxiCell or Chiba. Again, not advocating for either of these. This is just what I have at my disposal. Whatever you use, whatever you're comfortable with, that's the needle you should use. And I like that because you can also sort of couple that with our introducer, our Timno introducer. So I use a Timno ACT device. It comes with a 19 gauge 6 centimeter introducer. That's what I park down to the lesion. And through that 19 gauge introducer, I can pass this narrower needle for my fine needle aspiration. And if I have sufficient samples with that, I tend to be done. If I have insufficient samples with that, then you can convert to a core needle biopsy. So that's why I like to use that particular introducer set, just because it works well with either of those needles, and I'm not having to, stick them more than once from the skin surface down to the lesion. Everything gets done through that same introducer. So what are the pros of doing CT-guided biopsy? Well, it's really your only option if it's a deep lesion. You can see the anatomy much better, typically. That's not always the case because, as I said, you get that real-time visualization of vessels in particular on the ultrasound. And, we're doing these procedures most of the time without giving contrast. So you don't really see the vascular structures all that well with these CT-guided biopsies. That being said, I frequently will give contrast while the patient's on the table. I'll have everything set up, have it right, ready to go how I want things. If I'm concerned about there being a vessel in the way and I want to be absolutely certain that I'm staying away from it, I'll do a contrasted scan, a limited contrasted scan right through the area that we're working at, and that way I can map out where things are at. That contrast doesn't stay in the vessels for long. It washes out as the procedure goes on, but it's good enough that I can get a safe roadmap to get down to the lesion. Now with CT-guided biopsies, there are lots of different approaches that you can use to get a needle to virtually any deep space within the head and neck. And we'll talk more about that. As far as cons go, the CT procedures definitely take longer than ultrasound. Just it's the nature of the beast. Everything's a little slower. And they're less available as well. I think most places have CTs and CT fluoroscopy, but you might have one scanner at your hospital that you can do it, whereas those ultrasound machines are very much readily accessible. And as I mentioned before, yes, this does employ ionizing radiation. This is not something that I worry too much about. Obviously, I want to minimize the amount that I'm giving the patient while doing this. I don't want to scan them unnecessarily. But also, you don't want to say, well, I can't possibly do this for risk of cancer induction from ionizing radiation. I think you have to be realistic when you weigh these risks and benefits. All right, in terms of patient positioning, I think that as a radiologist that does a fair number of these, I can work around the patient most of the time. So to me, the most important thing is to get the patient comfortable, because if they're comfortable, they can hold still. And you want them to hold absolutely still during these procedures, or as still as possible. So whether the patient is laying perfectly flat on their back with their head looking straight up, whether they're rolled a little bit to their side, whether they've got their head turned to their side as we're mocking up in this picture here, to me it doesn't really matter. We can be flexible and work around things, but we want the patient to be comfortable. I tend to put the patient feet first into the gantry for these head and neck biopsies, just because if you put the patient in head first, patients have broad shoulders, some broader than others, and patients are of variable body sizes. It can be hard to reach over a patient to get to the head and neck region if they're a larger patient. So you put them into the scanner feet first. That way, you're really just worried about the width of their head, the diameter of their head, and you've got much more room to work. And then, as I said, variable positioning. We can do lots of different approaches to getting this done. It depends on what you're trying to get to, where the lesion's at, but also patient comfort. We're going to drape these in a sterile manner, just like we did with the ultrasound-guided procedures. I tend to use a lot of blue towels. Call me a prima donna. I'm okay with that. But I think it's important that you want to be absolutely as clean as possible in doing these procedures. The other thing that I like to do is I put them way back beyond where I'm working, because that way I have built myself a workbench. I have a place where I can put needles if I need to. I've got a place where I can put lidocaine, lay it down. That way, this is all a sterile field that I'm working in, kind of minimizing my motion instead of having to kind of go back and forth getting supplies. Use the same kind of standard biopsy tray. Don't need to go into too much depth about that. You can see the laser line. That's really important with these CT-guided biopsies, because that shows you exactly where things are lined up in your scanner. So you want to stay in the plane of the laser. Try to go perfectly within that plane, and then you just sort of torque your angulation around the clock face in terms of figuring out your trajectory of the needle. All All right, let's talk about some of these different approaches. So the first approach is the sigmoid notch approach. This is a lateral to medial approach. It's going to work through the sigmoid notch here. So up above that, you can't see it here because it's, missing, but up above that, superiorly, this is going to be bounded by the skull base. Anteriorly, we're going to have the coronoid process of the mandible, posteriorly the ramus of the mandible. So this is a big window that you can put needles through to get to deep spaces within the suprahyoid neck. And it gives you access to the masticator, parapharyngeal, pharyngeomucosal, retropharyngeal, and perivertebral space, specifically the prevertebral component. So as we're looking at this coronal diagram, we're sort of going below the zygomatic arch and sitting in that notch. So we're working lateral to medial, and we can get to lots of these different deep spaces of the suprahyoid neck. Here in axial diagram form, you can see we're shooting that notch. We can get to any of these deep spaces within the suprahyoid neck that way. Here's an example of how that might look when you're doing a CT-guided procedure. Here you can see the needle advancing in. In this case, I was putting a needle to the pterygopalatine fossa. This could either be done for a biopsy or for a trigeminal nerve block. Here's an example of a sigmoid notch approach. This is a patient that had a history of oropharyngeal squamous cell carcinoma that underwent radiation therapy, and then they had this new hypermetabolic retropharyngeal mass. To me, it's not a great mystery as to what this is. This almost certainly is going to be recurrent disease, but they needed samples for molecular genetic type assessment for triaging and sort of catering their medical care. So this is how we positioned the patient. They were more comfortable on their side. That was fine. I can work around that and just sort of shoot that sigmoid notch all the way down to that necrotic retropharyngeal lymph node. And this was recurrent disease in this case. This is an example of using that sigmoid notch approach to get a little bit deeper to the central skull base. And this is a patient that had a childhood hemangioma that was radiated, and they had had sort of this indolent progression of paresthesias going on. On this coronal T1 post-contrast image with fat saturation, we can see thickening and enhancement of the third division of the trigeminal nerve extending down through the foramen ovale. Here we can see that same effect on the axial T1 post-contrast image. It's uniformly and avidly enhancing, and it's thickened. They needed a biopsy because they were concerned that this might be like a malignant degeneration. So use that sigmoid notch approach, did an FNA of the trigeminal nerve, third division of the trigeminal nerve, and this came back as a malignant peripheral nerve sheath tumor. Next approach is the paramaxillary approach. Sometimes this is referred to as a transfacial approach. And you're shooting the gap between the maxilla and the mandible, kind of traversing through that retroantral fat pad and buccal fat. So this also gives us wide access to lots of these deep spaces within the suprahyoid neck. This is sort of our trajectory. So we're working anterior to where we were at for that sigmoid notch approach. In this case, we're sort of going right behind the back wall of the maxilla and going through that buccal and retroantral fat, as well as traversing the infrazygomatic masticator space to get down to these deep lesions. So here's an example using that paramaxillary approach, getting to something down sort of in the retropharyngeal region, just lateral to that margin of the pharyngeomucosal surface to take a biopsy sample. Here's another example of a paramaxillary approach. This is a patient that was a young to middle-aged lady that had a history of papillary thyroid carcinoma, that had had surgical resection and prior radiotherapy. They noted that her thyroglobulin levels were rising on surveillance, had a PET CT that was performed. And in this case, you can see kind of a classic pitfall. We have this lateral retropharyngeal mass here that shows no FDG uptake. And as we look at this, it's almost entirely cystic, maybe just a very thin rind of enhancement about it. This is a cystic retropharyngeal lymph node. It's so cystic, in fact, that it doesn't have enough substrate within it to take up FDG. So how do we get to this? Do that paramaxillary approach, part the introducer needle there, FNA this, and ended up doing a thyroglobulin washout, which confirmed what this was, which was metastatic adenopathy in a cystic retropharyngeal lymph node. So nice example of the paramaxillary approach. Also, nice example of a classic pitfall with differentiated thyroid carcinoma, in which you can have cystic mets that don't take up FDG. This is another paramaxillary approach. This is a patient who was at an outside hospital, was told that they had a calcified meningioma that was causing cord compression. One of my neurosurgical colleagues cruised by the reading room and asked me to take a look at it, and it said, this doesn't really look like a meningioma. This looks like just retrodental degenerative pseudopannus, and that's also what neurosurgery thought was going on as well. And they needed to decompress this because it was causing cord compression, and you can get the sense that the patient was developing some cord signal abnormality. But they wanted to be absolutely certain before they went in to do surgery that this wasn't tumoral, that they need not do any sort of, major oncologic type surgery, but instead all they needed to do was debulk. And so I agreed. We want to minimize the risk of the patient to more aggressive surgery if we can. So in this case, I'm able to use that paramaxillary approach and put a needle all the way into the foramen magnum, but contained within this soft tissue component. This came back as degenerative retrodental pseudopannus. So confirming what we thought, but at least we know the patient can get by with a less aggressive surgery, and in the end, that's good for them. All right, the next approach is the submastoid approach. This is a lateral approach that you work beneath the mastoid tip, and you're going to work medial to the mandible, okay? And this gives us access to the masticator space, the deep lobe of the carotid space. You can get to the perivertebral space with the prevertebral component. And if you're really aggressive, you can even get all the way out to the lingual cortex of the mandible. So this is sort of our trajectory. Again, we're going submastoid. You can just barely see the mastoid tip here. So submastoid, and we're working from posterior to anterior. So this is a patient that had a mass that needed biopsied, and just an example of that submastoid approach to get down to it. So this is that same patient, just to tell you a little bit more of the story. This one really was not a diagnostic dilemma as far as I was concerned. You can see that they have this mass within their suprahyoid neck, tracking along the carotid space, encasing the carotid. It's very, avidly enhancing. But if you look, it's not just there. This is transspatial. It's actually all the way up intracranial. You can see these dural tails of enhancement. This was growing up through the jugular foramen. This was a meningioma, really to no one's surprise. But this is a big surgery in a young patient, and the surgeons wanted to be absolutely certain that they didn't need to do anything in terms of gross oncologic resection, and to make sure that they could just debulk it as best possible to try to preserve as much function as she still had in her lower cranial nerves. And so, I did this submastoid approach to get them the answer, and yes, this was in fact a meningioma. Next approach is the retromandibular approach. This is a posterolateral approach that we work medial to the mandible and lateral to the mastoid. And so by doing this approach, we can get into the deep space of the carotid space, the parapharyngeal space, all the way down to the pharyngeal-mucosal space if we wanted to. We can get retropharyngeal, and we can get to that prevertebral component of the perivertebral space. So in this case, it's sort of a transparotid approach. So we're working from lateral to medial, but instead of going posterior to anterior, we're working, again, lateral to medial between the mastoid tip and the backside of the mandible. So this is an example of a retromandibular approach. This is a patient that we were pretty certain what was going on here. They've got this tubular mass. It's heterogeneous in signal intensity, but some areas that are pretty T2 bright, relatively poorly enhancing. We thought this was most likely going to be a neurofibroma extending along the facial nerve. The surgeons wanted to at least confirm that so that they didn't do anything crazy like a big, mass resection of the parotid and sacrifice the facial nerve function. So I was willing to do that with an FNA of this, and it confirmed that this was in fact a neurofibroma, and we really biopsied to avoid surgery. And so one of the things that comes up, people are always concerned with this approach, this retromandibular approach, is, am I at risk of injuring the facial nerve? And with the small gauge needles that we use, it's very incredibly unlikely that you're going to cause any sort of injury to the facial nerve. Honestly, the facial nerve and its branches just sort of get pushed out of the way as the needle advances. I will say that I've had one time ever in which a patient woke up from the procedure with weakness on that side of the face, and it's obviously a terrifying thing whenever that happens. But use your head, think it through. And what had happened in that case was I had anesthetized the facial nerve when I was numbing things up, one of these facial nerve branches, monitored the patient after the procedure. The facial nerve function recovered, after about an hour and a half, and it was back to baseline. But, when something like that happens, get on the phone, talk to the referring docs. In that case, I talked to the head and neck surgeons and let them know, just so they can, know up front, hey, could there possibly have been a complication? We always consent patients for this sort of thing. Just know most of the time that if they have any sort of weakness after the procedure, it almost certainly ends up being that you've anesthetized the nerve while numbing them up, and watch them and, plug them in to see facial plastics as soon as possible if there was something that was more of a lasting deficit, because there is the potential that they can do facial nerve reanimation, or they may even try to just do aggressive steroids to try to calm things down, just in case it's a post-inflammatory thing. So I'll get off of that soapbox. Just be aware that people do have concerns sometimes about this approach, and I'm here to tell you, I've done a lot of these. The risk is actually incredibly, incredibly, incredibly small of causing any sort of significant facial nerve injury. All right, and then the last approach is what I like to call the MacGyver approach. Okay, so sometimes those traditional approaches that I talked about just aren't feasible for any number of reasons. Okay, whether it's the patient's anatomy or it's a weird lesion in some weird location, and you have to improvise. And so I think while these end up being kind of exciting, sexy procedures, up front, the first rule that I talked about at the beginning of this talk is first do no harm, okay? Don't get so creative and don't get so cute and fancy that you're going to do something that's unnecessarily risky for the patient. Think through it, plan in advance, know the anatomy, weigh all of your options, okay? Things that may come into play here would be bleeding risk. So you want to make sure you've got that neurointerventional or endovascular safety net. Sometimes this is things I think about when I'm dealing with lesions around the airway. So you always want to have airway protection available. And sometimes I'll even do these cases under general anesthesia, so they already have an endotracheal tube in place. And then try to keep it simple, okay? Again, we're not trying to use like a Rube Goldberg machine to try to do the craziest, craftiest procedure possible. Keep it as simple as possible. Okay, so here's just a few examples of this. First example, this is a patient that had a salivary duct carcinoma that was resected. It was in a parotid that was resected. They had chemotherapy. They had radiation. And, maybe it was a year or two after that upfront surgery and after the initial course of chemoradiation, they developed a T2 bright enhancing lesion along the lingual surface of their mandible. And so the concern was, is this a bone met? And so could the surgeons get to this transorally? Yes, they could. It's feasible. They could do a surgery and go rooting through there and try to get to it. But that's more invasive. And so they reached out to me and asked if there's any chance that this could be done under CT. And, sure enough, yes, you can. So using sort of this modified submastoid approach, I was able to work from posterior to anterior with a very long needle and sneak it all the way up to the lesion and take some FNAs of this. And fortunately, this came back as osteoradionecrosis, rather than tumor. So obviously you don't want the patient to have osteoradionecrosis, but that's better than having, bone mets. And so that's good for her, and the other thing to keep in mind is in terms of patients who have been radiated, they really try to minimize any sort of instrumentation of the mandible or maxilla if it's been radiated due to the risk of worsening osteoradionecrosis. And so this is potentially a safer way of getting to an answer in this case. This is a patient who had a childhood nasopharyngeal carcinoma. Now they're a kind of a middle-aged adult, but their childhood nasopharyngeal carcinoma was treated with radiation, and now they have severe trismus. In fact, their trismus was so bad that they couldn't open their mouth more than a couple of millimeters. And the surgeons tried their best to scope the patient, get in there, take a look at things. I mean, they knew exactly where to look. We've got this lesion down toward the base of tongue. It's all sort of, this looks like it's going to be squamous cell carcinoma. But they could not try as they might, they could not visualize this to get a biopsy to confirm it. And so in this case, they asked if there's any way I could do the procedure. And so, I thought things through, and, this is sort of not a standard approach. It's sort of a retromandibular approach. But in this case, I went through and through the mucosa. So I literally went straight through the mucosa, through the atmosphere, and into the tongue. So, whenever you're crossing those sort of mucosal surfaces, there is a risk that you're going to seed your biopsy area with infection. It's a small risk. And so this is a case that I did give the patient prophylactic unison just to make sure that we're covering our bases for antibiotics. But on top of that, I also intubated the patient to protect the airway. Just in case this thing broke free and bled or developed a hematoma, I didn't want to lose an airway in a patient that could hardly open their mouth. So this is a patient that anesthesiology had to come down and do a fiber optic intubation to sneak this endotracheal tube down. This is a patient that had what was thought most likely to be a thyroglossal duct cyst. I mean, it's a good location for one. We've got this mixed cystic and solid lesion. But the concerning thing was there was calcification within it. We can see this area of calcification. So in terms of biomarkers for concern for thyroglossal duct cyst carcinoma, when you see calcification, that should always be viewed with great suspicion. The soft tissue components within it, you can get that from prior infection or inflammation of a thyroglossal duct cyst. It may be cancer, but commonly that's due to prior infection or inflammation. Whenever you see calcification, you have to be worried that you're dealing with thyroglossal duct cyst carcinoma. And so the surgeons asked if there's any way that I could get a needle down to that, because it's a little bit more challenging for them to try to do this transmucosally. And so I did sort of a lateral approach, sneaking between the hyoid bone and the thyroid cartilage, and was able to do FNAs, and this came back negative for malignancy. So that's reassuring for the patient. This was a patient who had a salivary ductal cancer of the orbit, status post-orbital exoneration, and they were in surveillance, and they were noted to have this area of FDG uptake and enhancement, and really kind of this rim enhancing area, and a little bit of gas in there as well. So this was read as concerning for disease recurrence with an area of necrotic tumor, and that's a fair thought. But it could also just be infection as well, a little abscess that's forming. And so they asked if I could get them an answer, and under CT you can put a needle into that, and did my biopsy, and sure enough, this came back as abscess with granulomatous reaction. But we're not done. This is why you look carefully at the salient pre-procedural imaging. What wasn't described was this. There's an enhancing nodule. And if you looked back on prior studies, that wasn't there. So while the patient was already there getting this biopsied, I went from a lateral to medial approach and biopsied this enhancing nodule, and that came back as recurrent salivary ductal carcinoma. So again, I'm showing this case to highlight the fact that you need to review the salient pre-procedural imaging, and have a plan. And that should include getting a good lay of the land and an assessment of what you think is going on clinically with the patient. This is a patient that was being evaluated for dysphagia, and they were unstable for endoscopic biopsy, and this actually ended up being around the holidays, and it was going to be hard to get the patient in to have GI biopsy this, and so they asked if there's anything that I could do. The patient was actually in hospital, sort of just waiting for the availability to get this procedure done, to get somebody to biopsy it, and endoscopy was really backed up, and it was going to cause a delay. And so they asked if it was something that could be done, and I said, sure, we can put a needle just about anywhere. And so this was an example of doing a transthyroidal biopsy down to the esophagus. In this patient, we confirmed there was esophageal carcinoma. So, you just have to be familiar with the anatomy and know that, it's safe enough to go through other organs if you need to. Assuming things like the thyroid are pretty safe to go through. I'm not sure I would, go through the carotid artery or anything, but you can sometimes think outside of the box and do something that's helpful for the patient. I think this is my last kind of MacGyver case. This is a patient who had known medullary thyroid carcinoma. They were in surveillance. They had rising biomarkers that were concerning, that they had recurrent disease. And so they had a soft tissue neck MRI that was performed. We noticed, I don't know how we noticed, but we noticed that there's sort of this T2 bright rim surrounding the vertebral artery flow void within the transverse foramen here. And so, you go back and look at old studies. This was a non-contrast CT from 2 years prior, and this was the size of that transverse foramen. And this is the size of it today. Something has been slowly growing and expanding that out over 2 years. That's not normal. So the patient ended up getting a dotatate PET CT, and sure enough, this was avid. Okay, but there were other sites. There was another site in the neck that was avid as well. So they had known nodal disease in the neck. And so the question was, if this was some sort of false positive, then they could have, still have potentially curative surgery with surgical resection of the nodes with a neck dissection. But if this ended up being a distant metastasis, then that changed everything for this patient. They're no longer a surgical candidate. They were sort of relegated to chemoradiation. So the question is, can you safely biopsy this? And so the answer is yes. You got to be careful about doing it, but it can be biopsied. And so I went for sort of this posterior approach and parked a needle right at that lateral margin of the transverse foramen. About to see it come into view about now, and then took some FNAs through that. Okay, so this is one that without question, I was on the phone ahead of time with neurosurgery, with the endovascular team that was covering that day, to let them know, hey, I'm doing a very risky biopsy, but it makes a difference for patient care. I want you guys to know, just in case something goes awry here, that they're ready to swoop in and do an angio if need be, and potentially do some sort of endovascular treatment. Fortunately, the patient did absolutely fine, no dissection, no injury or anything to the artery. And this, unfortunately, for the patient came back as metastatic medullary thyroid carcinoma with a perivascular metastasis. And so that made a big difference in the patient's management, because now they were sort of in that camp of chemo rads as the only management that they could have. Some of the other procedures that we can do are pain procedures. So we've got, like in this case, a trigeminal nerve block. This is the equipment that you need to do this are basically a CT scanner with CT fluoro, 25 gauge needle, and myelographic safe contrast material, so ISOView 300M. You also want to have some drugs to give them as well. So we give a dexamethasone, which is a non-particulate steroid, a little bit of bupivacaine. That's kind of our cocktail of drugs. And then, some myelographic safe contrast, either ISOView 200M or 300M, either way. And so in this case, we do a sigmoid notch approach. I'm parking the needle here just lateral to the foraminal valley. So this is going to be a cranial nerve V3 trigeminal block. When you park the needle there, you need to do a test injection of contrast just to make sure that it's not vascular. Even though, dexamethasone is a non-particulate steroid, you still don't want to give them intravascular steroid if you can avoid it. Potentially there would be a risk of embolization and stroke, although maybe that's more theoretical if it's a non-particulate steroid. But I would certainly only use non-particulate steroids for this type of thing. And then I always take a post-procedural image because I want to see where that contrast is spreading. So here's a cranial nerve V2 block, sort of that sigmoid notch approach, parking a needle at the lateral margin of the pterygopalatine fossa, just deep to the pterygomaxillary fissure. Do a test injection of contrast to make sure it pacifies, make sure it's not zipping away in veins because you frequently have a venous plexus that sits there. And if you do see that intravascular contrast, then you just need to sort of manipulate the needle, move it a little bit, get it out of that, and do another test injection and make sure it's not rapidly washing out. And once you've done that, then you're safe to give your cocktail of dexamethasone and bupivacaine. And this is our cranial nerve V3 block. Again, sort of that sigmoid notch approach, putting the needle just lateral to the foraminal valley where cranial nerve V3 exits the skull base. test injection of contrast. It was spreading the way it should, so it was safe to give our drug in that case. You're probably, those with eagle eyes are saying, well, what about this? This patient had a tandem cranial nerve V2 and V3 block. So this was just the contrast that was from their cranial nerve V2 block, not rapidly zipping all the way out here. We can also do cervical selective nerve root blocks. Same sort of setup, CT scanner with CT fluoro, 25 gauge needle, myelographic safe contrast material. Drugs, again, same exact drugs. Non-particulate steroid is what we use here. In this case, it's a lateral approach. We're parking the needle sort of along the posterior margin of that neural foramen. I always look at the pre-procedural imaging. I want to know exactly where the vertebral artery is to stay away from it. And, we want to do that test injection with contrast before we ever give this cocktail to make sure that we don't have vascular administration of the drug, and then take a post-procedural image so that you can, tell them where it spread to and make sure it's going along the expected course of the nerve. So in this case, we had the needle parked just at the sort of posterolateral margin of the neural foramen, do our test injection of contrast. It's not zipping away. It's not getting into the vertebral artery. So we know it's a safe needle position, and at that point we can give our steroid cocktail. All right, the very last part of this talk, I'll talk briefly about skull-based CSF leaks. Sort of the classic imaging tool that we have to use for this is going to be cisternography. For a cisternogram, we do lumbar puncture and administer intrathecal contrast, and then follow that by high-resolution skull-based imaging. So depending on whether you're doing CT cisternography versus nuclear medicine versus MR cisternography, contrast-enhanced MR cisternography, I should say, you'll have different contrast agents. You always want to use, if you're using iodinated, it always needs to be myelographic safe. So like ISOBU 300M is what I use for this. In terms of nuclear medicine agents, that can vary from site to site. Where I've been at previously, technetium-99M sulfur colloid was the agent of choice. And then it's off-label use to do this. So you have to consent the patients for it. It has to be done really in just a selective small subset of patients. But you can do contrast-enhanced MR cisternography with intrathecal administration of multihance. I give 0.5 ml. You probably could get by with even less because a tiny amount of contrast really makes your CSF bright. When I do these, I do a combination. I don't just do multihance by itself. I also do some ICV 300M with it, so you can actually make sure as you're doing that fluoroscopic guided lumbar puncture that it's going where it needs to go and you've got true intrathecal administration. So it's a complex pattern to try to decipher when you want to do this, when you don't want to do this. Most of the time, you don't need to do a true cisternogram, okay? And some of the questions you're going to want to try to tease out are, am I looking for a binary test? Do they have a CSF leak or not? Or is it somebody that's high risk for a CSF leak and you're trying to localize it? So somebody that's got multiple skull-based defects, you're trying to figure out where exactly the leak may be. As I said before, this does require, or potentially can require, the off-label use of intrathecal gadolinium if you're doing MR cisternography. And there is, in my estimation, there is variable sensitivity of the different agents and techniques. I will show you at the very end of this talk some very preliminary data, and I will say it with the caveat that this has not been peer-reviewed or published yet, but it's data that I think shows at least that there may be some superiority of one of these techniques over the others. So in a patient that comes to you with concern for a skull-based CSF leak, I'm not talking about spinal CSF leaks, this is skull-based CSF leaks. The first step is to do high-resolution CT imaging of the skull base. If there is not a hole in the skull base, if there is no osseous defect, they don't have a CSF leak. You are done. If they have a skull-based defect on that high-res CT, then the next step is not imaging. It is to collect fluid and do a beta-2 transferrin assay. Whether this is an anterior skull-based CSF leak with rhinorrhea, or if this is a lateral skull-based leak with otorrhea, collecting fluid is the next step. If that beta-2 transferrin assay of the fluid that's been collected comes back as negative, they don't have a CSF leak, you are done. If that beta 2 transferrin comes back as positive, then you know they have a CSF leak. That protein, beta 2 transferrin, is specific to CSF. So if it's positive, they have a CSF leak. If you have a hole in the skull base and a positive beta 2 transferrin assay, and where that fluid is at makes sense relative to where that hole in the skull base is at, and you have a definite source, you're done. You don't need any further imaging. They don't need a cisternogram. But there are times that you don't have a definite source. They may have multiple skull base defects. They may have had a complex prior craniofacial and skull base fracture pattern that you're not exactly sure where that leak is coming from. That's the time where I think it's helpful to do a combined MR and CT cisternogram. Now, there are people who say CT cisternogram is good enough, and many times it is. But I think that you can really increase your sensitivity by doing a combined CT and MR cisternogram. Now, there are rare occasions in which the beta 2 transferrin comes back as non-diagnostic, or they couldn't collect fluid, or it's an intermittent leak. And despite the fact that I've had some skull base surgeons tell me this never happens, this happens, okay? I've had this happen as recently as within the last 6 weeks. And I've had this happen numerous other times in the past. There are times that the beta 2 transferrin is either can't be collected, or they get such a tiny amount of fluid that it's really questionable as to the validity of it. And so there are times when it potentially is non-diagnostic. That to me is the other time that you may consider doing some sort of a combined cisternogram or some sort of cisternography. Okay. This ends up being a small minority of cases. Okay, so cisternogram techniques. If we're doing MR cisternography, I like to do a pre-contrast MRI. I'll show the protocol for that in a minute. If we're not going to do MR cisternography, then obviously we don't do the pre-contrast MRI. These patients will have a lumbar puncture done under fluoroscopy. So here's what that looks like. So this is a lateral image. You can see the needle going in, parked in the middle of the spinal canal. Give contrast. In this case, we give IsoView M300. We want to use the more dense contrast because it's going up to the intracranial space, so we want to make sure we make it as dense as possible. You may or may not give multi-Hance with that. If you're thinking about doing a combined MR-CT cisternogram, obviously you do. And if you're doing technetium-99M sulfur colloid, you can give that as well. Some places just give the sulfur colloid. I think that's fine if you want to do it that way. I prefer to make sure that you have a true intrathecal administration, that you don't have a split injection and we're just pumping a bunch of sulfur colloid into the subdural space. So my take is I always end up giving some iodinated contrast. All right, then with the patient's feet locked into place, with these, bootstrap things that look like some medieval torture device, to be perfectly honest. We keep the patient anchored to the table and we tip it head down, and that allows you to get intracranial contrast transit. It spreads from the lumbar spinal canal all the way up to the intracranial space and the subarachnoid space. I will warn you, the vast majority of patients, the second that it hits the intracranial space, they get a headache, and it's a pretty significant headache. I tell them that up front. I say it's almost certain you're going to get a bad headache as we're doing this. Don't be alarmed. It's self-limited. Sometimes patients get nauseous with it as well. Have some Zofran ready to give them if that happens. All right, then we do our skull-based CT. I was at a shop previously where we had spectral CT. I like to use spectral CT to really ramp up that K edge of play off of that K edge of iodine and make the contrast really stand out. If you're doing like the nuclear medicine version, you potentially could do a SPECT CT as well, or sometimes they just want to do planar, although I think planar probably has the lowest sensitivity for these leaks. And then potentially if they're doing the nuclear medicine agent, you're going to have pledgets placed ahead of time as well. I'm not really going into that, but you can also have pledgets placed up in the nasal cavity, and they can take those pledgets out after the procedure and put them in a well counter and get radioisotope counts from that. So that is one way you can up the sensitivity of the nuke med cisternograms as well. And then if we're doing an MR cisternogram, then we do an MRI of the skull base. We'll do an immediate scan, do a scan check of it. If we have the leak, we're done. if we don't see a leak, then hang on to them for 4 hours and bring them back and repeat scanning. I will say that when I do this, my first thing I do if I'm doing a combined CT MR cysternogram, after I've put in the contrast, the combination of IsoView M300 and that 0.5 ml of multi-Hance, I take them straight over to the CT scanner. Because A, I want to make sure that all that contrast is up intracranially, because you can't really see that on the fluoroscopy. And B, if I see a leak at that point, we're done. They don't need to go to the MRI. If I can localize the leak off the CT, we can be done. But most of the time, we don't see the leak initially off that CT, so they go to MRI. Okay, so this is my MR cysternogram protocol that I put together. Prior to lumbar puncture, they do an abbreviated MRI. I always do a diffusion because, hey, anytime a patient's getting in the scanner, they need a diffusion as far as I'm concerned. I do a 3D T2 space. I do thin slices with that. I can recon in the sagittal and coronal planes. I also do a sagittal 3D T1 space with fat saturation. One of the few times in head and neck imaging that I do a pre-contrast T1 with fat saturation. This is one of those times you want to do it. And the reason being is you want to see if you've got intrinsically T1 bright fluid opacification of the sinuses or middle ear mastoid. And you can, recon that in multiple planes as well. I also do coronal and T1 fat saturation thins, kind of traditional TSE imaging as well. Then the post-LP initial MRI, I do the same things. I omit the diffusion, I omit the T2 space, but I'm going to do the T1 sequences, and then I do a scan check. If I see a leak at that point, we're done. If not, I'll bring the patient back in about 4 hours and repeat it as well, because there are a significant number of patients that have very slow or intermittent leaks that don't declare themselves on the initial scan, but do declare themselves on the delayed scan. So here's just an example of what these look like. So this is a patient that they were very concerned had an anterior skull base CSF leak. Here we can see there is a defect in the roof of the sphenoid sinus. We've got a fluid level. This is incredibly compelling in and of itself. This is when we asked them to do a beta-2 transferrin assay, and this happens to be one of the examples in which they came back as non-diagnostic or they couldn't collect fluid. So it does sometimes happen. So the surgeons wanted to know up front, what they were getting into. They certainly could do, intraoperative fluorescein, lumbar puncture with intraoperative fluorescein as well. That is a totally acceptable alternative to doing this as well. But they want, where I previously was at, that was sort of the standard was we did these cysternograms. So do the fluoroscopic guided lumbar puncture, give the contrast, and we can see there is dense contrast layering within the left sphenoid sinus. This confirms that we have a anterior skull base CSF leak. This is an example of a nuclear medicine cysternogram using SPECT-CT. So here we can see that axial CT cysternogram component that was obtained as part of that SPECT-CT. Very subtle finding, but there is increased attenuation within the external auditory canal. Something's getting leaky over there. We can look at this source image on the SPECT, and you can see that there is abnormal radiotracer activity external to the cerebral spinal fluid spaces within the external ear. And here we can see that sort of bleeding over on the fused image. And so really, to me, I think probably the best role for these nuke med cysternograms are for whenever you've got a non-diagnostic beta-2 transferrin assay and a contraindication to MR cysternography, because these, at least based on the data that I've been able to collect, this ends up being the least sensitive tool for looking for a CSF leak. Okay, so here's my example of an MR cysternogram. And this is, as I said before, whenever I do these, I give a combination of the IsoView M300, 10 ml of that, and a 0.5 milliliter of multi-Hance into the intrathecal space, run that up to the head. I whisk them straight over to CT, do the skull-based CT imaging. In this case, we can see there's a pacification of the middle ear, but it's not dense. It is less dense than the contrast opacified subarachnoid space. Here, we can see it's opacified. It is not as bright. So the problem we have with CT cysternograms is we're looking for something bright, which is contrast, up against a backbone of something that is really bright, which is bone. It can be incredibly, incredibly hard to see contrast against that backdrop of bone within the interstices of the middle ear and mastoid, all those septi. It can be very, very hard. This was a case that was a false negative CT cisternogram. So didn't see a leak up front, whisked them straight over to MRI. This is not a T2 weighted sequence. This is a coronal T1, 3D T1 space with fat saturation, and we can see all of that gadolinium opacifying the middle ear and also the mastoid in this case. So nice example of a positive MR cisternogram with intrathecal gadolinium and the associated false negative CT cisternogram. So again, this has not been published or peer reviewed. I will be upfront and tell you that. I'm working on putting this together currently. But, in 30 consecutive cisternogram patients that we looked at, you can see these were the various sensitivities and specificities of MR versus CT versus SPECT CT. So they were all 100% specific. Okay, so if you had a leak on it, it was real. Okay, that's not shocking. But you can see there's actually pretty significant differences in the sensitivity. So around 89% sensitivity for MR. We had one false negative case. 80% sensitivity for CT cysternography, and 67% sensitivity for SPECT CT. So just keep in mind that there are varying sensitivities and specificities of these different tools that we have to use. Okay, so in summary, I provided you an imaging-guided, kind of an overview of imaging-guided head and neck procedures. And these, if done correctly and done with appropriate planning, can be very safe and very effective procedures for your patients. As I said before, knowing the anatomy, having a good understanding of the anatomy is really most of the battle here, okay? You want to make sure that you evaluate that on every single patient ahead of time. And as I said before, that whole mantra, measure twice, cut once, you want to have everything planned out ahead of time. You don't want to be operating in the realm of reactivity. You want to be proactive, and you want to know what you're going to do if something goes awry during the procedure. But hopefully with very thorough pre-procedural planning, you avoid all of that. And then just to bring home the point, I started the lecture by saying this, and I'll end the lecture by saying this. The first rule is to do no harm, okay? You always need to keep in mind that there is a real live patient who has a livelihood, who has family. You want to make sure that whatever you do for this patient, you're doing it in a safe way and in a way that will be hopefully having a meaningful impact on their medical decision-making and their medical care as a result of the procedure you're doing. So with that, thanks for tuning in. Hopefully you found this to be a helpful lecture. If you're enjoying these lectures, I would encourage you to subscribe to my channel, where I occasionally put up new content, talking about different things within the realm of neuroradiology and head and neck imaging. So again, thank you for the attention, and enjoy.